Afternoon, everyone. My name is Leah Grant, and I am the Divisional Vice President for Merritt Hawkins. Thank you for joining us for today's presentation titled, What I Wish I Knew Before Going into Primary Care. We are honored to bring this presentation to you live from our partnership with AMN Healthcare, specifically Merritt Hawkins, as well as Healthy Careers. Prior to starting, we would like to personally thank Healthy Careers for the partnership in bringing this event together. We genuinely appreciate your partnership with us. Today's presentation will be a real-life discussion about what our three panelists wish they knew prior to taking their first role within primary care. We are honored to have a set of panelists from different backgrounds and equally scattered across the US, working in different settings. In a moment, you'll have an opportunity to meet the panelists, but first, I would like to take an opportunity to introduce you to our moderator today, Dr. Jeffrey Kakish, as well as tell you a little bit more regarding who we are as AMN Healthcare, specifically Merritt Hawkins. Merritt Hawkins and AMN Healthcare is the nation's leader in full-service physician and clinical executive search services. We have the honor of representing over 3,000 permanent physician, mid-level, and academic executive search assignments each year. Our knowledge of the healthcare executive recruitment space has been built on over 30 years of providing clinical and academic physician search services, during which time Merritt Hawkins has been far and away the industry leader in both service, scope, and quality. We are here to help and guide you through these difficult times as a resident in the midst of COVID to guarantee that you choose the right family medicine or internal medicine practice for you. Now to meet your moderator. I am honored to have the opportunity to introduce you to Dr. Kakish. Dr. Kakish leads the Northeast Division for the Department of Academics, Cancer Centers, and Children's Hospitals for Merritt Hawkins and AMN Leadership Solutions. Dr. Kakish is currently a lecturer at the Physician Executive MBA program at the Haslam School of Business in the University of Tennessee, Knoxville, also where he received his MBA. Dr. Jeffrey Kakish is licensed, owns, and operates an assisted living program through the New York State Office of Mental Health in the Hudson Valley. With over 15 years of medical and social service in the healthcare industry, Jeffrey has the advantage of combining his medical education with his executive leadership MBA and his talent of building relationships with healthcare institutions by providing inclusive, diverse insight for growth. So we are honored to have him as our moderator today. Now, on to the presentations. Please note, as the presentation and the panelists are speaking, you will have the opportunity to utilize the question and answer. We will address the questions and answer at the very end if we have time, and even if we don't, I will personally reach out and be sure that we have an opportunity to address them. So without further notice, I will pass this off to Jeffrey Kakish. Enjoy.
Hello, everyone, and thank you, Leah, for that introduction. I would like to introduce our participants today. We have three panelists with us. Dr. Shahnaz Iqbal. Dr. Iqbal is the Assistant Chief of Medicine and Recruitment Chair. The Assistant Chief in Medicine and Recruitment Chair of Credentials and Privileges at Kaiser Permanente. She completed her undergraduate at UC Davis, where she received her bachelor's in animal physiology and a minor in psychology. She received her medical degree from New York Medical College in Westchester, New York. She completed her residency at UCSF Fresno in internal medicine and was chief resident. She joined Kaiser Permanente in 2002. Dr. Iqbal is a board certified in internal medicine and works full-time providing both inpatient hospital and outpatient clinic care. Also with us today is Dr. Sabel Pacheco. Dr. Pacheco is the Department Director for Geisinger Primary Care Services across 3 Western Pennsylvania counties. She's the Medical Director for Geisinger Urgent Care Services and Geisinger's Medical Director of Quality and Innovation for Primary Care. Dr. Pacheco received her medical degree from the American University of Caribbean School of Medicine in St. Martin. She completed her residency at Excella Health's Latrobe Family Medicine Program in Latrobe, Pennsylvania. She's a fellow of the American Academy of Family Physicians. Dr. Pacheco also received her MBA from the University of Scranton, and she joined Geisinger in 2013. Dr. Pacheco is a board-certified family practice physician. And lastly, and a pleasure to have, is Dr. Francis Runas. He is Site Medical Director at AltaMed Huntington Park Clinic, a large FQHC that currently serves over 300,000 patients annually in Southern California. Dr. Runas did his undergraduate at UCLA. He received his medical degree from Ross University School of Medicine in the Caribbean. Dr. Runas completed his residency at Arrowhead Regional Medical Center, and he's a board-certified family medicine physician. Thank you all for your time and sharing your experience with us today. To jump in, I'd like to start with Dr. Iqbal. Dr. Iqbal, can you please share what led you to become a primary care physician, and do you feel you made the right decision going into primary care?
So thank you so much, and thank you for having me. So my first interaction with physicians was when I was a child. I broke my arm when I was very, very young, 5 years old. And so I was taken to the hospitals a lot. And I just really admired my primary care physician and just the whole process of it all. Being so young, I had not been presented with anything outside of my house and my school. So I really didn't know about medicine, about opportunities that were available to me. I'm Pakistani and I was very sheltered. I didn't have any mentors, female or male, that I had went to college. And so it was really exciting to me to see life outside of just labor work and that type of thing. So as I grew up, I always focused back on that injury that I had and going into the hospital and seeing other professions. And so growing up, that was always in the back of my mind. So I was one of those people that I always wanted to be a doctor. That was the only thing I wanted to do. And so then reality hits you, you know, when you go into undergrad and then you make other decisions and you have other opportunities in life. I didn't get into medical school in the US the first time around. So I applied to a school in the Caribbean. I went to St. George's in Grenada and started my career there and transferred to New York Medical College in my third year in my clinical clerkship. So that I went kind of roundabout, but ended up where I was supposed to be. And I have no regrets. I know I talked to some colleagues on days where we're super busy or things we don't have time to spend with our families or we're just rushed. And I know colleagues say, well, you know, I should have been a specialist or I should have made a different life career choice. Me personally, I've never felt that. I'm exactly where I was supposed to be. I love my job. I love my career. Not to say that it isn't a lot of hard work. And some days I wish I could just call in sick and take the week off, but I have no regrets of going into primary care.
A right choice indeed, and well accomplished, I may say. Thank you, Dr. Iqbal. Dr. Pacheco, would you mind sharing with us what led you to become a primary care physician, and do you feel you made the right choice in going into primary care?
Sure. Again, thank you for having me as well. This is a real honor and a pleasure to be a part of. I have a little bit of a longer history than you, Dr. Iqbal. I started my career in medicine. Well, I would say that I wanted to be a doctor too as a child. I mean, I think that's going to be the common theme here, right? But I became a nurse. And that's what I did first. And I worked in oncology stem cell transplant in a very busy downtown Manhattan hospital. It was an incredible experience. I loved nursing primarily because it's very patient focused and patient centered. And I feel like, you know, as I've become a doctor, and I'll talk about that in a second, has a little bit of a different focus. Fast forward, I went through 9/11 in a downtown ground zero hospital, and it was life-changing. And I really knew then that I wanted to contribute more to medicine and be a little bit more in charge of the patient treatment plan and the care. So I too went off to medical school. I chose to head into the Caribbean for those first 2 years, and life was tough in St. Martin. But I made it. And I did my third year of medical school in London, which was an incredible experience looking at socialized medicine and just all that brings. But really more importantly, really honing in on diagnostic skills versus relying on ancillary testing. And came back and did my fourth year in New York again and decided I wanted to be a surgeon. So I went to surgery. I did a surgery residency for 2 years at University of Connecticut. And it was a really busy colorectal cancer program. I got really good at putting lines in the ICU, because that's what you do your first 2 years of Gen Surg is you spend it in the ICU, getting really good at taking care of very sick patients. And when I woke up, because I slept as much as I could, which was very little, I decided that what was I doing? And I was missing out on all the great things that is primary care, which in my opinion now is truly the foundation of medicine. So I missed all the relationship building, and I missed all of the discussions about social determinants of health. And I missed all those things that I get to do in addition to treating diabetes and hypertension and heart failure. And so I took a gap year in the middle of my life, my adult life. I regrouped and I decided to do primary care in an unopposed residency program in Latrobe, Pennsylvania. I'm from Manhattan. I like Chinese food at 2:00 in the morning, and that was all done. And so I lived there. I became a Steelers fan. I recruited into Geisinger and have spent the last 8 years of my 20+ year career in medicine in primary care. And it has been the best decision I could have ever done. As you can see from my title, I have transitioned much of my practice into administration, because at this point I have a lot to offer, I feel, in terms of policy and procedure and just making this better, not only for patients, but for our providers in primary care, and really honing in on quality, because I know none of us went into this, or none of you are going into this thinking, I want to do this, kind of just a little bit. You want to do it all the way. And quality is just that. It showcases your work. And the other part to this is that because I'm no longer in the specialty world, I get to really be patient focused and patient centered. So it's not about necessarily my decision making all the time, but really I become part of the team. So I have no regrets. I love it. I can't wait to continue and do more in primary care.
Thank you, Dr. Pacheco. And I could say that I'm sure that all of your patients truly appreciate all the services that you have given them, just as Dr. Iqbal just as well. Dr. Runas.
Okay, thank
Can
you very
you
much.
please share with us?
Sure. First of all, again, I want to extend my thanks to you, Jeffrey, Dr. Kakish, and our team at AMN for inviting me here today and to be allowed to present along with my esteemed colleagues. One common thread that it seems to be running across the three of us is that we all made it off off an island somewhere, and that, for those of you who are residents who are watching us today, I hope that that's inspirational, and to know that you can go through sometimes a crooked line, and then that may be the best route for you, because those experiences shape who you are, and I'm so thankful for them. Similar to what Dr. Pacheco and Dr. Iqbal said, I didn't go straight into medical school from undergrad. I have no shame in saying it. I was probably a little overconfident coming out of UCLA. I thought, to that point, everything had worked out. I took all the right APs in high school. I was in the right major in undergrad. Got like a 35 on the MCAT. I was like, oh, someone's gonna take me somewhere, right? And then, but to Dr. Pacheco's point, or to Dr. Iqbal's point, I didn't have a template. I didn't have someone that I could follow here in the United States. My parents are first generation immigrants from the Philippines. They don't know what medicine is like in here, and you'll find out that that's very much the case. Like, not having that was kind of a little bit of a hurdle to overcome. So that's fine. I ended up applying initially, didn't get in. So I said, okay, well, how can I improve my application? Well, I wanted some practical experience. So I ended up working as an EMT. I worked 911 in Inglewood, California. And in 2005, that was when Hurricane Katrina hit New Orleans and the Gulf Coast. And we were able to go over there. And I remember caravanning, like after the mayor of New Orleans was on CNN just saying like, we need help. And then my boss was like, you want to go? I said, yep. And thankfully it was at that point in my life when I could go. And, you know, I was there triaging patients, you know, to get helicoptered out of the convention center and I was like, you know, this is rewarding. This is super helpful. But at the same time, I was frustrated by my lack of scope. I was like, what am I doing as EMT? I really need to be in medicine, and doubled down. I swallowed my pride. I said, let me go to the Caribbean and see what happens. And thankfully I was able to come back. And that's one of those things when you're going through rotations in school and you're rotating on these US hospitals, the attendings and the staff, the nurses, they will see it. They'll see if you're sincere, if you're caring for your patients. And I think that for many of us who apply to med school, a lot of us put on our essays, oh, I want to serve the underserved, you know, and I'm thankful that I'm actually living that right now in terms of actualizing that dream. I'm working for a federally qualified health center. I didn't even know what that was until I finished residency, actually, until I started my position. So to answer the question about, you know, I'm happy going to primary care, I would have to say yes. I'm still very thankful to be where I am. The exercise of, you know, like what if, in terms of, for many family medicine doctors, part of what attracts us to it is because for some it's different aspects, right? Some people like the continuity, which is one of the reasons I like primary care. Some people like the procedures. So if you're working in a small clinic setting, or even if you work in a rural ER, you can do some outpatient or ER work. So that kind of jack of all trades thing, as a family medicine physician, it definitely appealed to me. So yeah, the what if exercise about, like, you know, what if I could have been like ER or other specialties, that's not necessarily helpful for me, because I'm very much so at peace with where I am. And the deeper I look into trying to what's it called, really understand and make as much impact as I can in my current role, the more fulfilled I've become. For instance, right now I'm working at AltaMed, which has an Institutes for Health Equity, which is very much in vogue right now in terms of addressing healthcare disparities. And I feel like I'm so proud to be working for an organization that started 50 years ago as ECLA Free Barrio Clinic. So I feel like, you know, we're not new to the game in terms of trying to address these healthcare disparities. So again, I love being able to come to work. I'm not going to lie to you that yes, there are long days, like just like Dr. Iqbal and Dr. Pacheco said, where you just don't want to get up in the morning. But then at the same time, you remember that you became a doctor because you wanted to serve, not because you wanted people to serve you. So I think that's one of the things that keeps me going. So thank you.
Thank you again, all three of you, for your leadership and experience in the front line of medicine and primary care. Going back and thinking, Dr. Iqbal, what is one thing you could do if you can go back and tell your younger you during residency program? What would you say to yourself?
Well, I think two main things. One thing I want to address, like Dr. Pacheco said, her pathway was a little bit different, and Dr. Runas also said it was a crooked line. And for me, it was as well. You know, I thought I wanted to be a trauma surgeon initially, but then I woke up and primary care is where I needed to be. So I think I would tell my younger self, just take it easy. You know, you're going to end up where you need to be in the end. But every little setback or every little step or every little hurdle, I think I would take it, and all of my colleagues would take those so personally. They would be devastating in the moment. And, you know, everything was so serious. And looking back, they were just steps to get you where you need to be. And, you know, I think I would not, if I had to go back, I would not stress over those changes. I would just take them with the flow and say, hey, this is the pathway I'm going to take. And maybe I'll loop back and maybe I won't. And to just kind of appreciate when life took me in a different direction, rather than just perseverating on it. Quick story was, my roommate and I were very disappointed at something, and maybe it was a test score or something. I just remember we were in her basement. This is in med school. We were in her basement, really upset, on the verge of tears, and her dad came down, and he said he was an Italian gruff dad, and he was like, "What's the matter with you guys? What's the matter with you guys? You guys are doctors. You know, you're going to graduate in a couple months, and you're going to go off." And and it kind of put things in perspective. And I think we in healthcare are so hard on ourselves, and we have to be forgiving. So if I had to go back, I think that's what I would do, is be more forgiving to myself.
Thank you for that answer. Dr. Pacheco, do you share the same sentiments?
I do. And
as
I would
Dr. Iqbal?
just, I do. And I would add one more step to that, Dr. Iqbal, which is, or maybe two more steps. One is you may outline for yourself what you think is the path, and it's okay to change. Because I thought I wanted to be a surgeon, and I started the residency. And as you can imagine, it was tough. But the other thing I think that I didn't consider when I was when I was training, or when I was before deciding my residency program, was what kind of a life that I wanted to have. And I really feel that that's a critical step when you're choosing a residency program, because I thought I knew what I wanted. And I will share a quick story too, which was, I was in surgery. My chief resident calls me to her office and says, I'm going to start this lap colon, but I'm 8.5 months pregnant. I'm on terbutaline because I'm contracting inappropriately. And I don't know if I'm going to make it through the case. And so I'm going to need you to take over if that happens. And I looked at her and I said, hey, why? You're having a baby. Like, that's more important. She's like, no, surgery is more important. And I knew then that I wasn't going to be a surgeon. And it was not long after that I changed. So I think it's okay, because we're all really focused and driven and dedicated to the field. But it is okay to be considerate of the kind of life that you want to have, and what it means, and what your career will mean, and the impact it'll have on that. So that's my only two bits of sense there.
Thank you, Dr. Pacheco. And Dr. Runas, you've scaled fairly quickly from residency into a director role. What is one thing that you would go back and tell your younger you during residency?
Sure. I guess I would say try to find out what most resonates with you in terms of your residency experience. What really makes you happy? What were your rotations or specialties that you're experiencing when you're in residency? Because then that's probably what you should be pursuing, because that's what you're going to be doing for a long period of your life. Now, again, your first job doesn't necessarily have to be your last job either. So I also would say, don't, to Dr. Iqbal's point, don't take yourself too seriously. If it's not a good fit, then you can try somewhere else too. So again, if you like the inpatient part of medicine, then so be it. Then work on hospitalist medicine. But if you like a different challenge every day, then okay, maybe locums are for you. Maybe you want to change locations every couple of months, and that's fine. Private practice, federally qualified health centers, academic medicine, whatever aspect of primary care or family medicine that you find interesting. I think residency, even though there's no time, I get that, but residency is a great time to be able to try to reach out to the people who you admire, like how they're living their lives, and say, well, how happy are you? How did you get to where you are? This is a time to reach out to those mentors, people who are already in places where you want to go, and then see if you can tailor that to you. Yeah, because it's one of those things where you don't want to just graduate and say, like, okay, what am I going to do now? So yeah, I think I would just say, yeah, try to find what really brings you joy in your residency, and then really try to pursue that. So
I couldn't agree with you more. You did not learn throughout residency.
I'm so sorry, it cut out for 1 second. What was that?
My apologies. I said, is there anything within primary care that you have seen change that you did not learn throughout residency?
What I would say is it's just kind of like sports now, actually, very much metrics based, right? You pitch to somebody based on what their stats are. You shift based on that. Medicine, more so being based on metrics. Dr. Iqbal was mentioning quality, or no, Dr. Pacheco, I believe you're mentioning quality as well, right? So how reimbursements occur with Medicare, patient outcomes, everything. When we say evidence-based medicine, that has to be in your practice. And so I guess one thing that has changed is that, like, whatever you learned in medical school, that's great, because you have to build on that, because it may be only applicable for right now, but there's going to be an update coming in the next month or the month after that. So I would say just having a mindset of that, like, whatever you learned, be prepared to unlearn it, because you have to be able to be flexible and adjust your practice as new things are discovered. So.
Makes sense. And yeah, I agree with you 100%. And Dr. Pacheco, would you mind emphasizing on that as well from your quality aspect?
Well, yeah, and just to reiterate, I mean, that is medicine. We're forever learners. So we're going to keep, the way we do things now is not the way we're going to do them in 10 years. I mean, it is what it is. I mean, the metrics and so forth, I think, is just another iteration of how far we've come to be able to track these kinds of things so that we can go back and make it better. So I constantly am tracking cancer screenings and how we care for diabetes, but it's not so much to tell you what you're not doing, but just to now layer in resources so you can do it. And so we can take the best care of our patients. I think the other thing that I wish that I maybe knew a little bit more about is just understanding the insurance world a little bit, because it is complicated and it does impact us as providers. Not that I would change my practice based on what someone's insurance has, but more, again, what can I give them, or what more can I do for them, based on those types of of those things. But I think it also helps me understand what my patient is experiencing on their end. So if they have a Medicare plan and don't have an Advantage plan, what does that mean for them? Or if they do have that, what does that mean for them? And so forth. And what's the benefit to them? And so I think it just makes us a little bit more well-rounded when we understand a bit of the business, as well as the clinical competency portion.
Absolutely. I couldn't agree more. And Dr. Iqbal, you have extensive experience in many stages of primary care. What is one thing within primary care that you have seen that you did not learn throughout residency?
Well, I definitely agree that my residency was not really focused so much on quality measures and billing and coding and documentation, and the real world really, really is. And so that's something I wish I had more exposure to in a certain part of my life. But now the facility where I'm at now, we don't have to worry about it as much, and we may touch on that later. But that is such a big, huge part of medicine, the billing, the quality measures. So I wish that residency had kind of prepared me for that. But the other thing also to kind of think about is when residents go out and look for career positions is look at what type of person you are. Are you independent? Are you a solo learner? Are you one of those that doesn't do research on your own, but is more collaborative with colleagues? It's very important, because when things change in medicine, sometimes they change slowly, but more often they change very rapidly. And if you're in a solo practice or you're in a small group practice and something happens, the Women's Health Initiative shows you how old I am. Who do you go to get recommendations, like what is the new standard of care? And then, more recently, the COVID pandemic, we were getting messages daily from our administration of what the CDC guidelines were, and they were changing daily and weekly. And so we were informed very, very well. And I can't imagine if I was in a solo practice out there trying to navigate these changes. So kind of look within yourselves and see what kind of person you are as far as collaboration or solo or independent and that type of thing when you're looking at practice.
Thank you for that. And you led me right into my next question of what are some of the things that were vastly different from residency versus working on your own. So I do appreciate that you shared a little more insight to that. Dr. Pacheco, would you be able to share a little more insight as to what you have seen different from residency versus current practices now? Yeah,
I mean, residency is meant to kind of give you the the snapshot of what it all will look like. And I think, you know, like everyone's residency, there was an inpatient component and an outpatient component. And I think when I came out of residency, I wanted both. And the reality is that it's really hard. It's tough to do them both well. And while it may, in fact, I just recruited somebody who wants to split position, and we created one for him, and we'll see how it goes, but it's a tough one. So, I mean, you know, I think you have to think about, again, like I say, lifestyle, because that's really important to me. I have a family. I wanted to continue education. I wanted to be in the PTO, but still be a doctor. And so I needed something that was going to be able to complement both of my personal needs. So I think, you know, I guess to Dr. Iqbal's point, you know, really considering, you know, solo practice, inpatient practice, outpatient practice, just thinking of all those things. The greatest thing about primary care is that there are so many facets to it, that there's not just one size fits all. I mean, it is really multidimensional, that you could really kind of blaze your own path. So that's my thoughts.
Thank you for that. And Dr. Runas, please give me your thoughts from an FQHC perspective versus residency. What have you seen different?
Sure. So I guess I'm thankful because the transition has been pretty smooth. Arrowhead Regional Medical Center is San Bernardino County's hospital. So it's just another name for San Bernardino County Hospital. So again, it's a safety net hospital. And FQHCs is a federally qualified health center. Again, and for residents or those who may be watching, it's basically, again, it's kind of a safety net organization to help provide care for patients, regardless of, you know, citizenship status, insurance status. So in that way, it's stayed kind of pure in terms of how it was in medicine. Like when you're as a resident, you just see who's in front of you, right? You're not worried about the billing thing, because like, as I agree with everybody else, that wasn't emphasized at all in my residency in terms of like, you know, having any business acumen. That was very, very like kind of like, oh yeah, you worry about that later. Like you'll learn that as you go, I guess. And at working in FQHC now, again, I want to say maybe 80. Yeah, more than half. I don't know that, I don't want to ballpark it, but definitely more than half of my patients are Medicaid patients. And so again, like to Dr. Pacheco's point about, you know, do you have a Medicare plan versus an Advantage plan versus just straight Medicare? So that means like I can just write the referral and I don't know where it's going to go anymore because I don't have to go through any approvals. So all those aspects of insurance that we still have to deal with, which again, Dr. Iqbal thankfully does not have to deal with because everything's in-house at KP. So I guess for me, it wasn't that much different because again, I'm used to a county setting where maybe I can't prescribe the latest diabetes drug, but I will try to figure out what's covered under your plan. You get really good at knowing what formularies are accepted. So I guess that's one aspect of working now then versus residency, is like you really have to make sure that you're offering the best care that you can, but you have to tailor that to your patient population. Yeah, so that's probably the main difference between residency and working at FQHC, is just that, again, you have to account for the fact that for some people, they don't have all the resources to be able to say like, oh, okay, you just need this procedure. Oh, wait, you have to wait for a county hospital, which it might take a couple months before you even get to see that specialist.
I appreciate it. Yes, definitely a learning curve for a clinically mindset mind to take into consideration that business healthcare aspect of insurances. Let me ask you, moving forward, what are some of the tips and suggestions that you would give to a resident that is considering opportunities and those learning curves, if you will?
So for my aspect on the federally qualified health center aspect, I didn't actually realize that working for an FQHC had some financial benefits as well. You don't necessarily have to be Mother Teresa and and say that just because I'm working at FQHC that you're living like a resident the rest of your life. There's actually some significant loan forgiveness programs by working in an underserved area. And so again, I thought that it was just like the 10-year public student loan forgiveness and that was it. But especially here in California, there's at least 3 or 4 different programs of which I was able to qualify for one. So again, if there's a panel, I mean, if there anybody who's watching has questions, I have no problem, delving into that deeper. But just, I guess that's one ancillary benefit, because in addition to the intrinsic benefit of, being able to care for my patients who I feel like need it the most, and I'm also able to provide for my family. To Dr. Pacheco's point, I do believe in work-life balance, and I want to spend as much time with my little kids as much as possible. So thankfully, I'm working a 4-10 schedule, so 3-day weekends ain't bad. So those are, I guess, one thing that I would have advice that I would have for residents would be to look for opportunities that fit, like Dr. Pacheco saying, your lifestyle. What life do you see for you, and then pursue those opportunities, because they're definitely out there. And if they're not out there, then maybe you can create it.
Absolutely. I couldn't agree with you more. Dr. Pacheco, how about you? Would you be able to share some tips and suggestions that you would give to a resident that is considering opportunities?
Yeah, I think everything that has been said. I think the other thing to think about is really doing just a tiny bit of homework on the organization that you're interested in. And I know Dr. Iqbal works for Kaiser Permanente, and I work for Geisinger, and Dr. Runas is at FQHC. So these are 3 very different models of care delivery within primary care. So, really quickly, you've heard a lot about the underserved. I have a, all payers are in on my particular healthcare organization. So while we are in the insurance business and have our own health plan, we also take all payers for the most part. And so what impact does that have to you and the organization that you're working for? And then, of course, as the provider in that organization, what does that mean for you? And this is a lot of information that I certainly didn't know. I don't think any of us knew when we picked where we were going to work or where we landed, but really, really important in the long term. And I'm sure Dr. Iqbal will talk about what life is like at Kaiser Permanente. I'm hearing she doesn't do billing and coding, so I'm thinking maybe I need to change jobs because or organizations. No, but I again, I think investigating the organization that you want to work for, how you want to practice in the long term. When you come out of residency, you're like, I just want to be a doctor, and I just want maybe my paycheck to look a little different than it does in residency. And I get that. I think we all went through that. I think you do have to think, what's it going to be like in 20 years? Because you're going to do this for a long time. And so we talk about work-life balance, and we're all at various stages of our career. And I'd like to talk about the organization that you pick, because I want to retire from Geisinger. I don't want to look for another job or go back into the market. I want to feel career satisfaction, professional growth, and then, of course, ultimately feeling like I've done the right thing by my patients and my community.
Thank you for that. And, I just want to emphasize more on, or do a follow-up question with you on your response just now. So considering that residents are getting several different offers and trying to make their final decision, what led you to accept your residency within Excella and move forward with your final decision, Dr. Pacheco?
So I chose Excella, and I apologize if I haven't correctly answered the question. I chose the program, the residency program I chose, and I'll take a step back and say that I had an offer to a program that was very highly academic in Atlanta, and I picked the program in Latrobe because it was unopposed. There were no other residents there. I got very dedicated teaching from all walks of life, from specialty to primary care to really even administration in the hospital. And it was a smaller group of people. So I was really fortunate to get every and any experience that I wanted. So I picked an unopposed residency. When I was in general surgery, it was a multi-residency program. So there were family medicine residents, gen surg, internal medicine, GI, you name it was there. But when you're in an unopposed program, there's no one but you. So when it's a GI bleed, it's you. Or, when it's anything, it's you as the resident, and everybody is clamoring to give you the experience. For the most part, attendings love to teach. I love to teach too. There's nothing like a learner. So that's what went into my decision-making about residency choice.
Thank you for sharing that. We appreciate it. Dr. Iqbal, considering the residents have several offers and trying to make their final decision, what are some of the tips and suggestions that you would give to these residents?
So first of all, I'd like to say that just be aware there's no perfect job out there. Okay, so you have to look at all aspects of the opportunities that are being offered to you, and just some tips on when you're interviewing. Ask to talk to different people, not just people on the panel, and then just ask them why they stay, why they chose going there, why they stay, and then what's the most frustrating thing of their job. So when I have applicants come out and we do a tour of Kaiser facilities, what I do is I introduce them to as many physicians as I can, and I will ask that for them. I will say to my colleagues, hey, tell our applicant, what's your favorite thing and why you stay here, and what frustrates you the most. So, for us, sure, there's no billing, we don't do the billing. You have to do your documentation correct, and the billing gets done. So your note has to be correct. That's easy. So, what's the frustrating thing? Well, the volume is so high, and our patients can directly email us. So some physicians have 30 to 50 personal emails a day that they have to take care of. And our expectation is within 48 hours. So, that's the give and take. So if you're one of those people that like that direct contact with your patient, and you don't mind answering some of the questions that you think are not doctor questions, then maybe we are the place for you. But if you're one of those people that you hate doing emails and that's not for you, then so look at the practical aspect of it, not just the money, the salary. I mean, those are all market standards, and they're going to be very similar in the benefits. But I think just looking at the day-to-day job, and also when you're exploring jobs, to ask working physicians, what does your day look like?
Great key points you just made. Thank you for that. And Dr. Runas, your tips and suggestions that you would give to residents that are considering opportunities and trying to make their final decision.
Sure. I mean, I think Dr. Iqbal hit that question out of the park in terms of, again, asking those tough questions in terms of, well, okay, one, like you said, first of all, what keeps you here and what makes you happy to be here? And then two, like, what are the worst parts of your day? Because that's not the stuff that's going to be in a brochure. That's not going to be on the website. So, I think being able to really, look at a job and holistically, the positive aspects and the warts and all, and figuring out how that fits with the lifestyle that you want to consider yourself living. I think that's the main thing. Because then the other thing is I don't think that again, like with Dr. Iqbal's point, you shouldn't just chase something just because you heard it was a good thing to go to. Like it should really make sure that makes that it fits you in terms of what will make you happy. Because what Dr. Pacheco keeps saying, you're right, you're going to be doing this for the next 20, 30 years of your life. So don't take a job that you think like, oh, I'm only going to do this for a couple months till something better comes along, because then that means you're not really going to put your heart into that, and that you're going to be cheating your patients as well. So you don't want to do that to yourself. So I would just say, yeah, just take your time, and then again, listen to Dr. Iqbal's advice. I have nothing to add to that. I think she did great.
That's great. One last question for you guys. You entered your careers into primary care. What led you from a practicing clinician into the leadership role? And I'm going to start with you, Dr. Pacheco.
I felt like that was coming my way. I think, to be honest, I got identified pretty quickly in my, and I'm seeing a lot of head shakes. I got identified really quickly after I started my job. I asked a lot of questions. I talked a lot, maybe more than I should, but was always interested in the why. And so, I started off with small small groups where for instance, I actually started leading the coronary artery disease bundle for us in primary care. It was really interesting, across specialties, talking about, industry standards and gold standard in treatment, and the expectation that primary care would have for patients prior to heading into a specialty, or utilizing specialty services. And then I, moved into performance improvement. So hearing cases where we were kind of talking about what went wrong. And I really enjoyed that, actually. As an aside, surgery does this really well with their M&M conferences. And I don't know that we do them as well or do them enough in primary care, but there are certainly always areas of opportunity. In fact, as I say that to you, we do our medical homes, and that's probably our M&Ms, really, right? But so I got identified that way. I honed in on organizational skills for myself, did a lot of follow-up. So I always keep a notebook. It's just my thing. I have something that I write down and I go back to and I cross off, and I'm a list maker and a box checker, and maybe that's the surgery. But I just did that. And I started to be identified as reliable and someone that, you could count on. Then I got given projects and let's see what you can do. And so I took the time, and in fact, I recently sat down as a woman leader, and, what would I be saying to myself, or what's it like having come through the system as a woman leader? And I just really, took my time, really was thoughtful about positions and committees and chairs that I was offered and able to take on. I said yes probably too many times, and got a little stretched at some points, but really was thoughtful about things that, again, resonated with me and felt right. And eventually was able to take on the department director. So I now was the leader for the department, and my department kicked it out of the park with quality. So I got pegged, go make it happen for community medicine. And I haven't done that yet because it's a really tough one, but just being involved, doing what you have to do, being reliable, following up on things, responding to emails. And this was a lot, I will tell you, a lot of my own time, but it was my personal investment in my future in administration and as a leader. And now I get paid to do it. So.
That's wonderful. And what a great background you have, and well-accomplished leader and clinician. Thank you. Dr. Iqbal, what made you go from clinical medicine to having that dual role of being a clinical leader as well?
I think I've always been a reluctant administrative leader. In my residency, my third year, we had a chief resident. We only had one, and he left after 2 months to just go pursue a career. And so we were left without a chief. And so the colleagues voted me to be chief, a third year chief. Weren't common to have third year chiefs back in the day, but so my colleagues selected me, and the reason they said that they selected me was the chief does the schedule, and they said that I would be fair. I would be the most fair person to do the schedule. So that was easy, being the chief resident. And then I was junior faculty at my residency for a couple of years. And then I actually worked at a county clinic for several years before I joined Kaiser Permanente. And then when I came to Kaiser Permanente, my chief I was here about 3 years, and my chief asked me to be FUM or module or pod lead. We have about 15 physicians in each pod. And I told him I couldn't do it because I was most junior, and there was no way I could lead people that were so senior to me. But he was one of those old-fashioned chiefs, and he kept asking me, and I kept saying no. And then one day he just sent the email out that I was the new pod lead. And so I was stuck in that position. So it's kind of just been like that. But I think, like Dr. Pacheco said, that, if you're responsible and you're honest and you're fair and you answer emails and you want to do what's right, you want to do what's right for your group, for your colleagues, and especially for your patients, I think it just kind of comes your way. And so, you know, my experience, it just kind of came my way in all different aspects. I love to teach, and that's one of the reasons I came to Kaiser Permanente. And we've been in and out with residents and students over the years. But when they pegged me for administrative duties, I said, no, I don't want to be the boss of other doctors. And they were like, no, it's not the boss. But, you know, if you have a knack for it, if you're just fair and honest, I think they'll peg you for it.
I agree with you 100%. And Dr. Runas, you know, you've scaled up into a leadership role fairly quickly in your career. Can you speak to what drove you to want to become a clinical leader?
Sure. I guess I would say that it's a personality trait that's probably similar to everybody who's on the panel, in terms of you don't necessarily have to be asked to be a leader, because just by virtue of being you know, competent and being, you know, like being willing to accept more responsibilities and looking for new challenges, then leadership eventually just finds you. You're like, oh, okay, that's somebody that we need to cultivate. And then so just again, I kept my head down. I just wanted to just be the best family medicine physician I could be. And then, as that turns out, that was the kind of material that leadership that the C-suite wanted to see. So, so I got tabbed, and then I looked at it as an opportunity to not only advocate for my patients, but also advocate for my fellow providers in my clinic, so that I can then be a voice for them. Because then, you know, instead of just as a way of amplifying my voice, instead of just being a staff physician, by being a director, then now I can really try to help affect change. And I think that little bit of having a little bit more responsibility is might be a little bit can be a little addictive, because now I'm looking for more responsibilities and more ways that I can try to change things and make things better. So again, I would say that again, most of the people who are watching this this forum right now, you got to med school not because you were a slacker, right? You got to med school because you were driven. You wanted to pursue this career of being able this very honorable career of trying to help people. So I would say, you know, just really tap into that. And then to me, actually, I feel like it's going to help with my career preservation, because they keep talking about nowadays, you know, physician wellness is a very important thing nowadays, and physician burnout, you know, and being able to take a little bit back from the you know, the everyday seeing patients, having a little bit more administrative time is actually kind of healthy for me to be able to say, like, this will allow me to serve for a longer period of time, and also hopefully make it better for my colleagues who are working in that front line day to day, you know. So again, that opportunity to be able to affect, you know, again, both my patients, more so my patients, and then also my colleagues in a greater manner versus just being just a staff physician. I think that was an opportunity I couldn't sit down.
Thank you again to you, Dr. Runas, Dr. Pacheco, and Dr. Iqbal for your time today, and well-accomplished backgrounds as clinicians and as leaders within primary care. Thank you all. I'm going to hand it over to Leah Grant now to give us some questions from the crowd that is viewing us.
Yes, and that was amazing. Thank you so much for taking the time to speak and review those answers and just give real life experiences. I would say that's probably the best of this all, the real lifeness of everything. We do have one question that came, and I would say this will be great for all of our panelists to answer. What might be some day-to-day differences between hospital-connected clinics and family or multi-specialty health centers, i.e. patient panel differences, post-discharge follow-up numbers, specialist referrals? So considering that you all have worked in different settings, what would you say is the key difference between working for a hospital-connected clinic or an FQHC or a multi-specialty group? And Dr. Iqbal, we'll start with you.
Well, I can say that when I worked for the county, you know, I just felt like it was all me, 100%. I didn't feel a personal connection with the specialists. I did have specialists I could refer to, but I didn't know when they were going to see the patient, that type of thing. And sometimes I had difficulty getting records from the hospitals, but mind you, I'm a little bit older and we didn't have EMR, electronic medical record at the time. So, but working at Kaiser Permanente, a multi-specialty center, is it's just amazing as far as getting your patients follow-up. So we can get patients in with specialists right away. I don't see people falling through the cracks, so to speak. I feel very comfortable with my colleagues and my specialists. And I'll be really honest, there were days I lost sleep when I worked at the county worrying about patients because they couldn't get in to see a specialist for 6 weeks. What was going to happen if they crashed in between? It was just going to be me. I just felt very isolated. But here, I don't lose a night's sleep. I know that I have specialists I can call. If the patient's not going to be seen within 2 weeks, I can still call them for some advice. And so we're huge, but we're very integrated. And most of us, almost all of us, know each other, and we're on first name basis. So that's the biggest change for me in the 3 areas that I've worked. I think I just feel the support in a bigger facility.
Thank you so much for that feedback. Dr. Runas, I'll pass it to you next.
Sure. Again, I would say that I would echo Dr. Iqbal's point. Working at FQHC is kind of like working at county. In terms of the patient population, it's not as integrated. I can't just say like I have a specialist under my roof who I refer to. We have people in the community who are contracted with. So then, again, it's the game of making sure that there's good follow-up, that they actually send the facts over or the reports of medical records that they're supposed to. Thankfully, that is improving slightly. For instance, like 2 years ago, we instituted Epic as our EMR. So thankfully, we can see all of KP's notes now, and then UCLA and some Cedars, all the different hospitals that use Epic in the area. So in that regard, sometimes at least I can be able to have that in-house, because that's one thing I missed from county was that from residency was that once they were admitted to the hospital, once I saw them in clinic, I had all their records already. But patient discharge from the hospital that I'm not affiliated with, and it's like, okay, well, we're gonna have to start from scratch here, and that's frustrating. I know that's not a problem that Dr. Iqbal has with Kaiser. So from that regard, yeah, there is a little bit more probably some extra steps that have to be taken to make sure that there's quality, to make sure that there's good follow-up, and then unfortunately some things that are systemic that may not be under your control. In terms of, like, again, if somebody who doesn't have insurance, doesn't have citizenship status, then there's kind of limited in terms of the access that's available. So you just kind of do the best you can. But again, working where I work, I know that our organization has tried to make that better in terms of we have a hospitalist team now, so that when there are discharges, the post-discharge notes, the hospitalist notes are actually incorporated in the EMR right away. So at least those discharges I know that I can follow up on right away. But again, if somebody goes to another hospital somewhere else, then it's just kind of a grab bag of what can happen. Yeah.
Awesome. Thank you for that, Dr. Runas. And Dr. Pacheco, we will finish up with you.
So I have a little of both because I'm not a closed system like Kaiser Permanente, and then we don't have a hospital everywhere where we have primary care offices. So when it's seamless, it's a patient admitted to one of our campuses, and then I too have Epic, so we can see everything. And so the transition of care is there, the follow-up, specialty, everything that we need is done, and that's from an admission perspective. But the other constraint that we have at Geisinger is that we have a large geographic footprint. And so there may be specialists outside our system that are closer for the patient to travel to versus getting into one of our hubs, which would be much further for them to go to. The good thing is that with some of that those exchange key high networks where we can get information across our electronic medical record, when we can, we do. But I deal with it in both ways. I deal with it out of system, specialty hospitalization follow-up, and in system. And by far, I think the key here is communication. How well is that done? And, it's better, it's easier when it's done, on one of our campuses. When it's not done, it's a little bit more challenging, getting old records faxed over, an ER report or a discharge summary or something like that. But I think, what has changed for us in primary care across the board And for us here in this country is that we are really moving towards a value-based system. And so everybody has their eyes on the prize about this, and it is important. And so regardless of where they go, for the most part, we're kind of working together for the good of the patient. And so they're not getting readmitted or having some untoward consequence of a comorbid or not. So it's a little of both.
Thank you so much for that feedback. And Dr. Runas, Dr. Iqbal, Dr. Pacheco, I want to personally thank you for taking the time to speak to our participants, speak to our residents today. It's been an amazing panel discussion, and I know the panelists are very appreciative of you taking the time out to share your personal experiences as well as expertise with them. That is a wrap for us, but I do want to let all of our participants know if you have any questions at all, please do not ever hesitate to reach out to Merritt Hawkins. This has been a pleasure, and I am honored to have an opportunity to even bring this to you today. Again, thank you each. Thank you, Dr. Kakish, Dr. Runas, Dr. Pacheco, Dr. Iqbal, and thank you, Healthy Careers, for partnering with Merritt Hawkins and bringing this presentation. I hope everyone has a wonderful afternoon, and we'll chat soon.
Thank you.
Thank you.